So welcome to the Kanski lecture series, and today we are going to start about the Conjunctiva part 6, and this part we are going to study about the miscellaneous disorders of the conjunctiva. So you cannot bring it into some category, but these are important ones, especially the superior limbal keratoconjunctivitis. So why it is called the superior limbal keratoconjunctivitis? Because in this case, the superior side of the cornea and superior side of the conjunctiva is involved. So that is why it is called the superior limbal keratoconjunctivitis, or you can say SLK. It is very common in a case of a thyroid eye disease, and when a patient of a thyroid eye presents to you with a you must rule out the you see the conjunctiva to see about the superior limbal keratoconjunctivitis. So let's get started. Introduction. Superior limbic keratoconjunctivitis SLK is a relatively uncommon chronic disease of the superior limbus and the superior bulbar and tarsal conjunctiva. So all the superior sides is involved. It affects one or both eyes of the middle-aged woman, approximately 50% of whom have an abnormal thyroid function, usually hyperthyroidism. Approximately 3% patient with the thyroid eye disease have SLK. So if a patient presents to you with this SLK, then 50% of them will have a deranged TFTs, and they will have a hyperthyroidism. And if the 3% of the patient with thyroid eye disease have a SLK, the condition is probably under diagnosed because the symptoms are typically more severe than sign. The course can be prolonged over years, although remission eventually occurs spontaneously. There are similarities to mechanically induced papillary conjunctivitis, and a comparable clinical picture has been described with the contact lens wear and following upper eyelid surgery or trauma. So, whenever the upper lid is involved, it causes the SLK as well. For example, if a patient has undergone the surgery of the upper lid. The condition is believed to be the result of the blink related trauma between the upper lid and the superior bulbar conjunctiva, precipitated in many cases by the tear film insufficiency and an excess of a lax conjunctival tissue. So, what is the pathophysiology of it? Because the conjunctiva is somewhat lax and loose, and there is a blinking is trauma, upper lid is heavy, so it causes the trauma in the conjunctiva, so that is why SLK happens. With the increased conjunctival movement, there is a mechanical damage to the tarsal and bulbar conjunctival surface that result in inflammatory response leading to increasing conjunctival edema and redundancy. Redundancy means basically loosening of the conjunctiva. With the creation of the self-perpetuating cycle, it may be analogous to conjunctivochalasis affecting the lower bulbar conjunctiva. So, we will discuss about the conjunctivochalasis. So, conjunctivochalasis is when the conjunctiva is loose on the lower lid, and you can see the shining reflex of the conjunctiva onto the on the lower eyelid. It is analogous to the conjunctivochalasis. In the superior limbal keratoconjunctivitis, the upper side of the conjunctiva is loosened, so it is analogous to conjunctivochalasis. So, how will you diagnose? Diagnosis inquiry should be made about the contact lens wear and previous eyelid surgery or trauma. Symptoms include the foreign body sensation, burning, mild photophobia, mucoid discharge, and frequent blinking, and are often intermittent. Conjunctiva. Hyperemia of the radial band of the superior bulbar conjunctiva that stains with rose bengal and may be best seen macroscopically. So there will be the hyperemia, the conjunctiva will be congested, but the superior bulbar conjunctiva will be involved in a radial like fashion, and that will stain with the rose bengal and will be seen. You will see the eye macroscopically, you can see without a microscope as well. So let's see figure 6.25 a. So this is a radial conjunctival congestion, and you can see that the conjunctiva is congested. Limbal papillary hypertrophy. Limbal palisades may be lost superiorly. Papillary hypertrophy of the superior tarsal plate often have a diffuse velvety appearance. So papillary conjunctivitis will set in the papillary hypertrophy in the limbal area, papillary hypertrophy in the tarsal plate. Light downward pressure on the upper lid result in the fold of the redundant conjunctiva crossing the limbus. So when you will press the upper eyelid, the loose conjunctiva will appear below the upper eyelid. Petechial hemorrhage may be present. Keratinization can be demonstrated on biopsy or an impression cytology. So it's not the keratinization is not visible, but you can see it on the biopsy or on the cytology. So what happens to the cornea? Superior punctate corneal epithelial erosions are common and are often separated from the limbus by the zone of normal epithelium. Superior filamentary keratitis develop in about one third of the cases. Mild superior painless resemble arcus sinalis may be seen in long-standing disease. Keratoconjunctivitis sicca is present in about 50%. So basically, the condition, the dry eye affects how the dry eye affects the cornea. Signs appear on the cornea. So there can be the corneal erosions, there can be the filamentary keratitis, and there can be the keratoconjunctivitis sicca. Investigation: thyroid function testing should be performed if the patient is not known to have a thyroid disease. Biopsy or impression cytology may reveal keratinization of the superior bulbar conjunctiva. Check thyroid function in a patient with a superior limbic keratoconjunctivitis. So treatment. So you know that the dry eye is common, so you have to give the lubricants in this case, and you can treat it with the topical steroid for the inflammatory component, and for the filamentary component you can give acetylcysteine, and you can, if there is a keratinization, you can give retinoic acid. Very simple. But if this condition is not improved, there will be another treatment, that surgical treatment we will discuss in this topic. So topical treatment: lubricants that will be the preservative free may be preferred to reduce the friction between the tarsal and the bulbar conjunctiva, should be used regularly and frequently. Acetylcysteine 5% or 10% 4 times daily to break down the filaments and provide lubrication. Mast cell stabilizer and steroids to address any inflammatory component. Steroid may be used, best used in short intensive course with the rapid tapering, and should be reserved for severe cases. Promising results have been reported with topical rabamipide, cyclosporin 0.05% twice daily as primary or adjunctive therapy, particularly in the presence of the coexisting keratoconjunctivitis sicca. So cyclosporin is also can be given, but as it is an immunomodulator. Retinoic acid to retard keratinization. Autologous serum 20% drops can be beneficial, but may require instillation up to 10 times a day. So autologous serum also provide lubrication, so that can also be applied. Soft contact lens which intervenes between the lid and the superior conjunctiva are effective in some cases. Interestingly, a unilateral lens may provide a bilateral relief. So it's very you can say astonishing thing that if contact lens is placed in a one eye, it produces a bilateral relief. Other thing you can do is a supratarsal steroid injection, which is 0.1 ml of triamcinolone 40 milligram per ml may break the inflammatory cycle. Temporary superior or inferior punctal occlusion you can do to prevent the dry eye, because when you occlude the puncti, the tears will not drain and will remain in the eye for the longer period of time, so it's quite helpful. Resection of the superior limbal conjunctiva, either in the zone extending 2 mm from the superior limbus or the area staining with the rose bengal, is often effective in resistant cases. Lax conjunctiva is removed with regrowth tending to be firmly anchored. There is no consensus as to whether underlying tenon capsule should be excised. So what can you do if the everything is not resection? You can resect that part of the conjunctiva which is inflamed and having an inflammatory actions. So you can remove the conjunctiva 2 mm above the limbus, or you can remove all the conjunctiva that has been stained with the rose bengal. Conjunctival ablation by applying silver nitrate 0.5%, not cautery sticks or thermocautery, to the affected area. Treatment of the associated thyroid dysfunction may improve SLK. So these are all the treatment of the SLK. So you can see the figure B is showing the hyperemic band of the superior bulbar conjunctiva with limbal papillae, and C is showing the diffuse velvety papillary hypertrophy. Now another one is a Legionnaires conjunctiva. So Legionnaires conjunctiva is basically when a patient is deficient in some anti-fibrotic uh, therapy. So that is anti-fibrotic agents. So it causes the membrane formation and a woody like appearance in the conjunctiva, and most of the time the children are presented with this case. Legionnaires conjunctiva is a very rare, potentially side and even life threatening disorder characterized by recurrent, often bilateral, fibrin rich pseudomembrane lesion of wood like consistency that develop mainly on the tarsal conjunctiva. So, there is a pseudomembrane formation of a fibrin rich material. We will know why it will be fibrin rich, because there is a deficiency of the anti fibrotic agents in the plasma. It is generally a systemic condition and may involve the periodontal tissue, the upper and lower respiratory tract, kidneys, middle ear, and female genitalia. Death can occasionally occur from pulmonary involvement. In susceptible patient, abnormal patterns of a damage repair are found, particularly failure of a normal clearance of the product of the acute stages of the healing process. So in this cases, basically the products that are in the healing process are not normally found, so that is why it is happened. This is manifested predominantly in mucosal tissue. A deficiency in plasmin mediated fibrinolysis may be the key common factor in many patient episode, may be triggered by relatively mild trauma or by systemic events such as fever and antifibrinolytic therapy. So what happens is basically the in the healing process, the plasma mediated fibrinolysis is deficient, so the fibrin is not getting lysed, and there will be the increase in the fibrin content, and which causes this kind of condition. And it does not only affect the eye, it can affect the systemic regions as well, kidneys, pulmonary region, and due to the pulmonary involvement a patient even can die. Diagnosis: histopathology show amorphous subepithelial deposit of eosinophilic material consisting predominantly of fibrin. So you can see figure 6.26a. So this is a Legionnaires conjunctivitis. A is histology showing eosinophil fibrinous coagulum on the conjunctival surface. So you can see this is a surface of the conjunctiva, and you can see eosinophilic fibrin component. Presentation is with non-specific conjunctivitis, usually in childhood, median age 5 years. Although onset may be at any age, a conjunctival lesion is commonly noted by parents. Gradually enlarging red-white lobular conjunctival mass, which may be covered by thick yellow white mucoid discharge. So there will be the mass that is gradually enlarging, and that will be the red-white, and there will be the mucoid discharge as well. Corneal scarring, vascularization, infection, or melting can also occur. So this is a Legionnaires conjunctiva. B and C is showing the multiple lesions in the eye, and D is showing the lesion removal. So these are the Legionnaires conjunctiva having a wood-like consistency and a red-white mass. Treatment tends to be unsatisfactory and spontaneous resolution is rare. It is important to discontinue any antifibrinolytic drugs. Surgical removals with meticulous diathermy of the base of the lesion. Preoperative topical plasminogen may soften pseudomembrane and facilitate removal. So if you give the topical plasminogen, which are like an antifibrotic agent, so it can also lose the pseudomembrane, and you can easily remove the lesion. Topical following membrane removal, only heparin and steroids are commonly commenced immediately and continued until the wound has reepithelized, with subsequent tapering over several weeks until all the signs of inflammation have disappeared. Recurrence may be retarded by the long-term cyclosporin and steroid instillation. Other modalities, intravenous or topical plasminogen, can be used. Amniotic membrane transplantation to the conjunctiva following lesion removal. Prophylactic heparin treatment may be of benefit prior to ocular surgery in at risk patients. So you can give a topical heparin treatment if you are planning to do any kind of surgery in a patient of Legionnaires conjunctiva. So next is a perinode oculoglandular syndrome. We have read it in the case of follicular. It causes the follicular conjunctivitis. It causes the lymphadenopathy. So two things you must remember. Perinode oculoglandular syndrome is a rare condition consisting of the chronic low-grade fever, uh, unilateral granulomatous conjunctivitis. So there will be the conjunctivitis, that will be the granulomatous with surrounding follicles, and ipsilateral preauricular lymphadenopathy. It is a synonymous with the cat scratch disease caused by the Bertonella henselae, although several other causes have been implicated, including tularemia, insect hair, ophthalmia nodosum, treponema pallidum, sporotrichosis, tuberculosis, and acute chlamydia trachomatis infection. So one thing you must recall, what is the most important organism that is associated with perinode oculoglandular syndrome? It is a Bartonella henselae. So this is a granulomatous conjunctivitis and perinode syndrome. So next is a factitious conjunctiva. So factitious conjunctiva is when the conjunctivitis that has been falsely induced, like a patient present with conjunctivitis, but there is no other reason because it is a self-induced conjunctivitis. Let's see how you can self-induced conjunctivitis. Introduction: self-injury, factitious keratoconjunctivitis. Why? Because you are self-injuring your conjunctiva. Is most often intentional, but can also occur in advertently, as in mucus fishing syndrome and removal of contact lens. So how you do it? Because you rub your eyes so much that it become red, and you can also do it unknowingly by removal, during the removal of contact lens. Damage may be the result of either mechanical trauma or of the installation of the inadvertent but readily accessible household substances such as soap. Occasionally, over installation of the prescribed ocular medication is also responsible. Diagnosis: reported symptoms may be seem disproportionate to sign. The patient may have sought multiple medical opinions over an extended period, often from a range of specialists for different complaints. So, patient do not have a one single complaints, but can be a multiple complaints, and also he has may have gone through various specialists to get the opinion. But in this case, you must have ruled out that the patient is self injuring his or her conjunctiva. Signs are inferior conjunctival injection and staining with rose bengal. So the rose bengal staining, and most likely the inferior side of the conjunctiva is involved, because you have more likely can cause damage to the inferior conjunctiva with quite superior bulbal conjunctiva, linear corneal abrasion, persistent epithelial defect, and occasionally focal corneal perforation. Secondary infection with Candida species, sterile ring infiltrate with and hypopion and corneal scarring. So it is all only, these are all the causes that can occur with the case of the trauma that you induce to the eye. So you can get the secondary bacterial infection and corneal scarring as well. Management is exclude other diagnosis. Close observation may be required. Confrontation often lead to failure to return for review. A psychiatrist's opinion may be appropriate. So this is a inferior conjunctival injection and staining with rose bengal and factitious conjunctivitis. So that's it for the cornea part 6. See you in the next lecture.